outcomes to be presented by Dr. Louise Yeung from Cedars-Sinai and Long Island Jewish Medical Center.
Good afternoon. I'd like to thank the SAGES Committee for the privilege of presenting our research today. Our group is interested in single-stage revision from a gastric band to either a gastric bypass or sleeve gastrectomy, looking at 6 and 12-month outcomes. We have nothing to disclose. So gastric banding, as we all know, is a restrictive weight loss procedure that's increasingly requiring revisional surgery for complications and failures. These complications could include band erosion, slippage of the band with pouch or esophageal dilation, or simply insufficient weight loss. When the band has failed, it can be removed and revised to either a gastric bypass, but increasingly, bands are also being revised to sleeve gastrectomy. And these revisions can be safely performed in 2 stages. However, given some obvious benefits to a single-stage operation, with the exception generally of band erosion, the safety of a single-stage conversion is also being investigated and demonstrated. The objective of our study was to compare the safety and efficacy of a single-stage revision from a gastric band to either a gastric bypass or sleeve gastrectomy, and following them at 6 and 12 months. As gastric bypass could have a higher complication rate, is the risk-benefit ratio offset by better weight loss and improved reduction of comorbidities. We performed a retrospective analysis from 2009 to 2014, looking at patients who underwent single-stage revision at a single academic center, and then we reassessed them for weight loss and complications. Baseline characteristics between the 2 groups were similar, but there were some differences. The bypass patients tended to be slightly older, with a higher percentage being revised for insufficient weight loss and a lower percentage being revised for band problems. There was also a greater percentage of bypass patients who had baseline hypertension and hyperlipidemia. But BMIs at the time of revision were similar between the 2 groups. So our peri-operative results showed that patients who underwent conversion to bypass tended to have slightly longer operating room times, with higher average estimated blood loss and a higher percentage of drains being used. And although the length of stay was slightly longer on average, this was not a significant difference. Looking at complications, within 30 days, although the reoperation rate looks higher for revision to bypass versus revision to sleeve, the overall rate of reoperation was so low that this was not found to be statistically significant. The number of ED visits, readmissions to the hospital, and overall complications, both major and minor, were similar between the 2 groups. Within 12 months, there were several more delayed complications in the sleeve gastrectomy group, but the overall complication rate remained similar between the 2. So looking more closely at the reoperation rate within the first 30 days, in the bypass group, there were 4 reoperations. 2 were for leaks at the GJ, requiring ICU stays. 1 was for a JJ obstruction, and 1 for post-op bleeding. In the sleeve gastrectomy group, there were 2 reoperations within 30 days. 1 was for a sleeve leak in a patient who broke diet protocol and started eating solid food less than 2 weeks after reoperation, and 1 for an incarcerated port site hernia. In the bypass group, there were 6 overall complications, both minor and major. The complications were graded according to the Clavien-Dindo classification system, with grades 3 and 4 representing major complications requiring interventions. And the major complications were the reoperations, as mentioned, 2 of which required ICU stays. In the sleeve gastrectomy group, there were 9 overall complications, and those requiring intervention were the reoperations mentioned, and neither of these patients required ICU stays. Within the first 12 months, there were no additional complications in the bypass group, but in the sleeve gastrectomy group, there were 6 additional delayed complications within the first year, and 3 of these required intervention. 2 of these were for strictures, which required endoscopic stenting, and 1 was for a port site hernia that showed up 6 months postoperatively. In terms of our weight loss outcomes, there was no difference in absolute BMI values between revision to bypass or to sleeve within the first year, Although if you look, the bypass patients had slightly higher starting BMI and slightly lower BMI measurements at each 3-month interval. And that may explain why when we looked at percent excess weight loss, we almost had a significant difference at 6 months, although this difference didn't quite hold as strongly at 12. And examining the change in BMI again was not different, although this showed a trend towards a greater decrease in BMI in our bypass group. Comorbidity reduction was examined by looking at diabetic and hypertensive medications. And while we weren't adequately powered to really show a difference, we did see a trend towards more reduction in medications for the bypass group at 6 months. And this reduction in medication seemed to hold for hypertension medications at 12 months. So in conclusion, single-stage revision from gastric band to either bypass or sleeve is technically feasible, but not without complications. And the complications in our bypass group tended to be more severe. Additionally, the one leak in our revision to sleeve group did involve some patient-related factors, and we found no strong difference in readmission or reoperation rates, weight loss, or comorbidity reduction. And so looking at this data, it appears that revision to gastric bypass trended towards higher rate and certainly greater severity of complications, but with equivalent weight loss and comorbidity reduction. Thank you for your time.
Yes, go ahead.
Enrique Kelly from UIC. Great presentation. 2 questions. One is, which is the criteria to decide between bypass and sleeve? And number 2, what is also the criteria to avoid single stage to a second stage?
Thank you for the questions. There were no strict fixed criteria for conversion to bypass or sleeve. We generally tend to follow the same guidelines that we would for a primary bypass or sleeve. Namely, our group tends to offer a bypass for insulin-dependent diabetics or patients with severe reflux. Otherwise, the conversion operation was kind of left to discussion between surgeon and patient. And your second question, in terms of aborting a single-stage procedure, that was, if there was any evidence of a band erosion, then we went to separate stages. And intraoperatively, if there was any concern with the dissection, any inadvertent concern for perforation, anything that sparked the surgeon to, on their judgment, state that the tissue didn't look healthy enough to continue, then we would also abort. But we didn't have a fixed set of criteria, no.
Thank you.
Thank you.
I have a question from the audience. Did you keep an option for rebanding?
So we trended to not offer rebanding in our group. I know that remains an option in some other centers. Our thought was that if they had failed the band, and we have a pretty good follow-up in our band program in terms of making sure that they're followed with fluoroscopy, and we're pretty careful with our band adjustments. And so generally, if these patients were having issues with the band, we really had no reason to think that they would do better with a repeat band. And so we tended to offer them a more definitive operation.
Here's another. Did you see more reflux in the patients converted to sleeve compared to those who have a primary sleeve?
So that's a great question, and that's actually being incorporated now into part of our database. We tend to assess the patients now for HQRL GERD scores, and so that's next on the horizon in terms of what we're looking at. But thank you for that question.
So overall, in your experience, are you now going to convert the bands in a single stage to gastric bypass? I mean, you had, you know, some pretty devastating leaks in the bypass groups.
Yeah.
And certainly a lot higher leak rate probably than for your, primary Roux-en-Y gastric bypass.
Mm-hmm. So in terms of our choices for conversion, I mean, it doesn't deter us from converting to a bypass if that's the best appropriate revisional operation. When we looked back at our data, the 2 leaks that we had were actually very early. Complication rate is higher and more severe, and I'm not downplaying that. But as our surgeons have gotten more comfortable and better, frankly, at the revision in terms of taking into account the patient factors, looking at removing the capsule or making sure that the capsule from the band doesn't play any factor into failure of staple lines and things like that. Certainly our leak rate has improved dramatically in more recent years. So I think that the bottom line is that the patients can be safely converted to both and there's certainly no contraindication to going to a sleeve.
Thank you very much.
Thank you.